Hello friends, Indian Chess Society, in association with its educational partner, Glenmark, has finished 15 Respinars, which involved nearly 100 pulmonologists all across India, from all the regions, and also had very interesting topics for the discussion. And it goes a long way to say that nearly 50,000 people logged in to watch this Respinars. It has become popular in our respiratory community. We are moving ahead, and in the month of May, we are going to bring you a hot mix and controversies in various respiratory topics in coming days. Keep watching them, and also remember, we have started along with API EPICS webinar, which is not only for the respiratory physicians but also from the physicians, and it is in association with API. Keep watching that, which is twice a month, and of course Respinar, which you have patronized so well in the last 3 months that we have reached almost each and every corner of India, with the topics so interesting, intriguing, with moderators doing excellent job and bringing out the best from our panelists as well as experts who are the top-notch pulmonologists in India. Keep watching and keep enjoying and keep sending your feedback to us. And I'm Dr. Deepak Talwar, signing off as well as requesting you to continue watching these Respinars.
Here we are again with another episode of Respinar, ICS Respinar, which we have been doing every Wednesdays. And as this is the month of different days of celebration, today we are discussing about pulmonary arterial hypertension, the myths, the controversies, and we shall also be looking at the ERS guidelines. So I hand over, before I hand over today's proceeding to Dr. Debra Jash, who is the moderator for today evening's Respinar, I would like to thank our knowledge partner, Glenmark Pharmaceuticals, who have made it possible to bring out this stage and help us interact not only among each other, but all over the country. Thank you so much. Over to you, Debraj.
Good evening, ma'am. So today we will be discussing about the pulmonary arterial hypertension, mainly focusing on the ERS guideline. For that, I want to welcome our lead expert today, Dr. Harjit Dhunra sir, and all the respected panelists, Dr. Brijesh Prajapat, Dr. Apar Jindal, and Dr. Licha, as well as Dr. Mihir. So we will be briefly discussing about the groups of pulmonary arterial hypertension, about the changes, what has been brought about by the European Society of Cardiology as well as the ERS guideline, and how far it is applicable in countries like India, whether we can follow all those things in our countries or whether there is any requirement of any newer guideline. So to cut short, I want to show a case and then I will start with the questions and I will go to the panelists, and everyone is welcome to interrupt at any point of time, even when the question is being thrown to the panelists. And I will take obviously the expert opinion of Dr. Dhunra. So please enable me to share the screen. Okay, I am unable to share the screen. For the time being, I will go straight away to Dr. Mihir. Dr. Mihir, are you there?
Yes, sir, I'm here.
Okay, so in our OPD practice, we used to see a lot of patients of the shortness of breath. So what particular symptoms will make you aware that whether the patient should be investigated for pulmonary arterial hypertension or not? Because in OPD practice, we see a number of patients presenting with shortness of breath. So which are the symptoms or what are the specific symptoms which will lead to think about the diagnosis of pulmonary arterial hypertension, or you will go for another sort of investigations or refer to someone else? So what are those symptoms specific to pulmonary arterial hypertension?
Good evening, sir, and good evening to all panelists and all our viewers. I thank ICS firstly for the opportunity that they have given us. So yes, indeed, in a respiratory OPD, we are likely to see a lot of patients with breathlessness. And as our guidelines say, when we are looking at a patient with breathlessness, one of the few features that we check are if the exertional breathlessness is with minimal exertion, has been suddenly progressive, if the patient has associated palpitations, has possibly has got hemoptysis also. These symptoms can sometimes help us look towards the diagnosis of pulmonary hypertension. But there are some red flag signs, like if they have syncopal episodes which are occurring because of minimal exertion or immediately post exercise, that can help us identify a person who is possibly in an intermediate or a higher risk category of your severe pulmonary hypertension, classes. So that is something that we could be looking for. Additionally, you would see patients with signs of right heart failure, so to speak, backward failure, in which they would have bilateral pedal edema, could be having abdominal pain and nausea after exercise, a hepatomegaly on your examination. So these kind of symptoms are something that we are looking for when we are looking for pulmonary hypertension. If it's a younger patient who has had breathlessness on exertion which is not explained otherwise, then that would be another category that one would want to start thinking about as far as pulmonary hypertension is concerned.
Thank you, Mihir. I will go to Dr. Dhumra. Sir, whether the shortness of breath, sometimes we used to say that shortness of breath out of context or disproportionate to the clinical signs. So will you make any point on that, or whether you will go straight away to the patients who are presenting predominantly with the features of right heart failure? Those. So do you have in your OPD practice the patients who do not have any features of that overt right heart failure, but from the symptoms you seem to presume that these patients should be investigated for pulmonary arterial hypertension? Question number one. And question number two, after that, I will ask you the new changes in the definition of the guideline of the pulmonary arterial hypertension and how practical it is for us pulmonologists who are practicing in countries like India to stamp a diagnosis of pulmonary arterial hypertension.
So very relevant questions, Devraj. First and foremost, in a busy OPD practice, like me just mentioned, looking at symptoms is just one part of the story. You need to suspect upfront which are the patients which might end up developing pulmonary hypertension. So rather than looking at every patient as a candidate who might end up developing pulmonary hypertension, there will be specific risk groups where you tend to suspect it even before it comes. So in fact, you can sort of localize that group early on. So if I have a patient of, say, for example, scleroderma, I might think of pulmonary hypertension early. If I have a patient of chronic liver disease who comes with, say, features where I can't explain shortness of breath, or a patient with HIV, or the patients with congenital heart disease, or patients who have family history of pulmonary hypertension, or a patient who has had a pulmonary embolism in the past. So these are high risk groups which possibly would make me suspect breathlessness of uncertain significance to be related to pulmonary hypertension when I'm screening them. So rather than looking at thinking of pulmonary hypertension in every patient who has out of proportion shortness of breath, let's focus on at risk groups. Secondly, if the patient can be run through certain basic investigations, or a patient is already coming to you with certain investigations. In our part of the world, a lot of patients with breathlessness will already have a cardiac assessment before they come to a respiratory physician. A physician would have done that. So a simple look at the echo or an ECG will also lead you to identify certain subtle features. And we are not talking about full-blown pulmonary hypertension feature of a cardiomegaly or an X-ray or a straightening of a left heart border. Subtle features on the ECG. So maybe there is a right axis deviation, maybe there is an RBBP, maybe there is a P pulmonary. All these things will help you pick up those patients rather than just focusing on symptoms. So that is the first part of the story. As far as the second question, which possibly is very relevant to India, is the definition of pulmonary hypertension. Now, since ages, in fact, since decades, since pulmonary hypertension was identified across the world, the definition is based on hemodynamic parameters, which are only assessed by right heart catheterization. And sad to say, in our country, right heart catheterization is neither asked for frequently, nor is performed frequently by our cardiologist friends. And we as pulmonologists have not graduated to that level that we do it on a frequent basis. So for us, in fact, to stamp a diagnosis of pulmonary hypertension is next to impossible. Why? Because right heart catheterization is the only gold standard to stamp it, which is not being done in our country. Now, how do you then, in a country like ours, stamp a diagnosis. So I've always believed that just because there is a lot of India in the peripheries, in smaller centers where facilities might not exist, people tend to take it as an excuse not to go for advanced investigations. But there are centers in the country which are doing right heart caths. There are places, there are hospitals which are accessible. There are cardiologists who are doing it. We need to find them and make them do this procedure. So just saying that because it is not available, because it is not accessible, because it is a highly skilled procedure, we should substitute with a different definition altogether is not the solution. The definition remains the same. That is the gold standard. It has to be on right heart cath. Now, surrogate markers in the form of an echo, in the form of a BNP, in the form of imaging, these can be used to identify which patients we should send for right heart catheterization. So you don't send every patient with breathlessness out of proportion, with an echo which shows pulmonary artery pressure which is high, or a BNP which is high for right heart catheterization. You screen these patients, rule out alternative causes of excessive pulmonary artery pressures. Say if a patient has left heart disease, patient has embolism, patient has a sleep apnea, patient has severe ILD, all those causes you need to rule out. And then if you cannot sort of explain the pulmonary hypertension on any other grounds, then you can send these patients to these highly skilled centers and you can possibly get a right heart catheterization. It is not impossible. Believe me, we have publications in our country on right heart catheterization, which means it is being done. And now there are transplant centers which routinely do right heart catheterization. Last bit about the change in the definition which you asked me as to what has happened. So previously the cutoffs for defining pulmonary hypertension was the mean pulmonary artery pressure of greater than 25. Now it has been brought down to greater than 20. So we are trying to identify these patients early. Obviously, early diagnosis will lead to early and appropriate treatment, improving prognosis and quality of life of patients. So that is the major change. There is something called exercise-induced pulmonary hypertension where basically you will not see these patients as having pulmonary hypertension on a routine cath, but you have to make them exercise and only then you will pick it up. So the main category is the mean pulmonary artery pressure. And then there have been some changes in the subsets. So now
the subset I will come later on. Sir,
okay, fine. That is the major difference.
In your day-to-day OPD practice, do you refer your patients, apart from those probably who are awaiting lung transplant, apart from those category, do you refer your patient routinely for right heart catheterization to you as well as all the panelists also?
So I'll let the panelists go first and then I'll come back to mine.
So, Devraj, if I can jut in over there, I think it is a must. We should, if we are thinking about pulmonary hypertension in a patient, there is no way whatsoever that we should not refer that patient for a right heart catheterization study. See, as Harjit put it, that is the only gold standard, and all definitions have been placed according to right heart catheterization only. So, RHC, again, he has put it very nicely that our cardiology colleagues are not, very upfront in doing right heart cath. They hesitate in doing, they are more comfortable with doing left heart caths. But I think it is time that we as pulmonologists, especially now that so many of us are foraying into pulmonary critical care domain, and all of us have associated ICUs, this is a procedure which can be very safely done in an ICU setting itself. You don't need a cath lab setting for this procedure. We all need to graduate to that level that we safely start performing right heart caths or get associated with our intensive care colleagues to perform this.
Sir,
I think it's a
understood. Yes, sir, understood. Now I will take opinion of all Dr. Brijesh as well as Dr. Richa. Do you refer your patient daily for right heart cath? Now, especially pulmonologists like Dr. Brijesh, who is very much conversant with echocardiography. I know him personally, he is very conversant with echocardiography. So, but most of the pulmonologists, those patients, even in the primary healthcare center, secondary or tertiary, whatever you will be talking about. So, how do we interpret whether the echocardiography is done rightly or not, or whether to take this pulmonary arterial hypertension report? Many times we have a report of mild pulmonary arterial hypertension, pH of around 45. So, how can we interpret whether the echocardiography has been done correctly by the cardiologist? Number one, many centers also use nowadays technician for the non-invasive cardiology part. And second thing is that should a pulmonologist know or learn how to do the echocardiography for the basic assessment of pulmonary arterial hypertension? And what are the variables we will look for while assessing PH?
So, Devraj, should I pitch in?
Yes.
Devraj, yeah. So, thank you, Devraj, for putting up this prudent question. In the last 2 decades, what we have done, we put echocardiography as the non-invasive surrogate test for the RSC, and that is the pitfall. Why we are not doing RSC most frequently? Because we have put echocardiography as the gold standard. Now, majority of the people see. I start with that thing. I was shy of this topic since beginning, because I thought this was a cardiologist domain, and now I believe this is an uncharted territory. Okay, cardiologists are more inclined toward the left side of the heart, and right side is an orphan thing. Okay, so coming on to this thing, the echocardiography can never be a gold standard. RSC is the gold standard, I agree, but the practice that we follow in our country, especially the north, we don't have regular centers for RSC in North India. In South, we have more centers of RSC. Correct me, Dr. Apar, if I'm not wrong. But in North India, we have hardly few centers which are doing the regular RSC studies. Especially if I refer the patient, my patient goes to 2 or 3 hospitals, and then it usually gets it done. Okay. So coming on to echocardiography, it will never replace RSC. The exceptions are very few. If the patient is not able to undergo the RSC, if patient is so moribund, we can surrogate echocardiography in place of RSC. Coming on to echocardiography, it's a wonderful non-invasive test to detect, to screen the pulmonary hypertension. One more important thing which I was always get confused, PAH and PH. See, we are dealing with PH. PH is just one subtype of PH, and it should always be borne in mind. We are dealing with PH. We screen PH. We never diagnose. We never screen PAH. We screen PH. In echocardiography also, we screen PH, never PAH. PAH can only be with validity diagnosed in RSC. Echocardiography is just a surrogate. It can say yes if the patient is not having any cardiac issues, if not having respiratory issues, then yes, very high probability of PAH. But echocardiography can only detect or screen for PH. So straight away going for the markers, going for the variables in echocardiography. Another questions that you raised, that we should be educated or trained in echocardiography. Yes, if you are doing a dedicated PH center, dedicated PH OPD, you should be well aware of all these variables. You should be know how to reduce, how to measure these variables in echocardiography. If you don't know, then it is also okay. You can get the help of your cardiology colleague who is well versed with measuring these variables.
Dr. At least we can exclude the left-sided heart diseases. At least we can exclude the left-sided heart diseases, which we already highlighted.
Cardiologists are very, very inclined towards heart disease. If you send any patient for echocardiography, he will say EF, he will say LA, LV. He will not comment directly on RA, until unless you ask him. So I think you need to tell your cardiologist something about this thing, that what you are actually looking for. Coming on to the variable directly, if you suspect PH in echocardiography, the important parameters are very few, like the systolic pulmonary artery pressures, which is actually an estimate of when you measure the regurgitant velocity, and when you measure the pressure gradient of TR, and when you negate the value of pulmonary stenosis if it is having, or when you negate the value of right atrial pressure, then you can have this estimate of SPAP. The recent guidance clearly says that if you can measure TRV, which is more than 2.8 or 2.7, then you can suspect PH in that patient. Apart from these pressure jets and pressure regurgitations, you can have the RV architecture, which can also tell you about whether the patient is having pulmonary hypertension or not.
It can prompt us to refer the patients for right heart catheterization.
Yes, 100%. If your patient is having TRV of more than 2.8 or 3 with the normal LV, normal LA, yes, these are the good candidate to refer the patient for RLC, I think. In addition, echo can also detect group 2 PH, especially the patients who are having the LV dysfunctions. And then echocardiography is wonderful tool.
Yeah. So now I will go to Dr. Apar. Among all of us, probably you will be most conversant with right heart catheterization. So I will be asking you straight away that how do we confirm the diagnosis by right heart catheterization? I will request you not to go into the vasoreactivity test part. I will first ask Dr. Rich and then I will take your opinion. And second thing is that even in the definition, there is a part that exercise challenge. So whether it is feasible to do exercise challenge while doing the right heart catheterization or you do routinely?
So let me answer the second question first. No, we do not usually do the exercise challenge. Till now, in my experience, I have not done a right heart catheterization with an exercise challenge in any patient. Now let me come back to the first one. That confirmation for the diagnosis of pulmonary hypertension. Yes, right heart catheterization is the tool to do that. And I'm not going to go into the specifics of how the right heart catheterization is done. But I think the important point to understand is the values and the variables that we come out with once the catheterization has been done. So it is important to understand that not only the pressures that, we've got the right atrial pressure, we've got the systolic, diastolic, and the mean pulmonary artery pressures. Only these do not suffice. You need to have some other variables as well. And what are the two major important variables according to the definitions as we were trying to bring in? I think those two variables are the wedge pressure, the pulmonary papillary wedge pressures, and the pulmonary vascular resistance. Based upon these, we can very clearly identify three different categories of pulmonary hypertension. One would be the pre-capillary or the actual group 1, the pulmonary arterial hypertension, wherein your pressures would be more than 20, the mean PAP. The wedge pressure would be less than 15 and the pulmonary vascular resistance would be high. That means, yes, the problem lies with the pulmonary vasculature alone. If we change this pressure reading slightly, and we say that the wedge pressure now is not less than or equal to 15, but more than 15, and the pulmonary vascular resistance is low, less than 2 Woods unit. This means that there is definitely more of volume overloading, more of backflow coming into the lung, which would classify as group 2 pulmonary hypertension, or as it has been called in the guidelines as isolated post-capillary pulmonary hypertension. If we make a combination of the two, that yes, the wedge pressure is also more and the vascular resistance is also more, this becomes a combined pre and post capillary pulmonary hypertension, which would mean that yes, there is an underlying lung disease or an underlying heart disease along with problems in the pulmonary vasculature. So is this enough that we've got these values? Is this enough to identify all the problems and to quantify and prognosticate the patient? I think no, we need a few more variables. And what are those other variables? We need to also know what the cardiac index is. We need to know what the stroke volume is. We need to know what the stroke volume index is. Like when Bridget was talking about echo, I think not just knowing about the velocity, but also looking at other things like what the TAPSE is, what the RVOT pattern of flow is. Similarly, in the right heart cath, also not just knowing about the pressures, but knowing all the associated factors that we get from the thermodilation principles is an important way how we can not only diagnose, but also prognosticate this patient. So I'll stop over here. Since you've asked me not to go into the vasoreactivity part of it.
Hello. Sorry, my connection got disconnected. Now I will go to. Am I audible to all of you?
Yes, Devraj, go ahead.
Yes. Now I will ask Dr. Richa. Dr. Richa, are you online?
Yes, sir.
Yes. So, Dr. Richa, what is your experience of right heart catheterization? And because in the guideline, it has been said that the vasoreactivity test, what are the agents which should be used ideally? Now, the problem is that the most of the agents which were written in the guideline are not that much commonly available in India. So, whether we should do vasoreactive test at all? Or whether there are any agents available in our parts of the country which we can use in our day-to-day practice?
Good evening, everyone. So I agree with all the panelists and seniors that right heart catheterization is the gold standard, and echo is just a non-invasive screening test. And luckily, the center where I am, there is pulmonary hypertension clinic going on, and regularly right heart catheterization is being done by the cardiologist. So because they are also running the heart lung transplant program, so it is a necessity before the transplant that the right heart catheterization is done. And also in the clinic, as we discussed, that all the patients where at least where there is severe pulmonary hypertension, specifically in lung disease, patient coming to me with underlying lung disease and patient has severe pulmonary hypertension, which is usually not expected, the decision is taken to go take that patient for right heart catheterization. Specifically, if I am suspecting group 1 and I want to label the patient, I want to, and as we know, idiopathic pulmonary arterial hypertension is a diagnosis of exclusion. So there, yes, RHC is also done in the group 1 specifically. So right heart catheterization in our center, and I have seen regularly, even at follow-up, he does that when he sees that the patient is not responding to the drugs that he has added. So maybe at 3 months, 6 months, he will again go ahead with the right heart catheterization. And vasoreactivity testing is also commonly done. Now, why are we doing that? We all know that we are looking at basically who are the patients, the small subset of patients who might respond to the calcium channel blockers, and it's mainly done in the group 1 patients, that too in idiopathic or maybe heritable, or where we can label drugs or toxins as the cause of pulmonary arterial hypertension. At our center, we are using it commonly. There is another center who are doing in Bombay. They also use inhaled nitric oxide because of its short onset of action and easy availability. And they use 10 to 20 parts per million. And when I asked around also, they don't really use inhaled electros, although it is recommended. Even IV ecoprostenol, it is not routinely used because of it requires a longer duration for the whole testing. So they do use inhaled nitric oxide, and basically they are looking at the drop in the mean pulmonary arterial pressure, of which is less than or equal to 10 millimeters of mercury, and an absolute reduction of 40 millimeters of mercury. Some patient where they will not do vasoreactivity testing is patients who already have low blood pressure, or maybe who are high on the function class, maybe class 4, or maybe with someone with low cardiac output. There definitely they will not go ahead with the vasoreactive testing, or maybe not the other groups also, where they feel that the calcium channel blockers will not help much. So the other group, they don't really go for vasoreactivity testing. But yes, inhaled nitric oxide is commonly used and is being done for the vasoreactivity testing.
Okay. Like
if I can just come in.
Yes, sir. I'm going to just for a minute. In our practice, also, I'm going to you only, sir. In our practice, suppose I'm sitting in an OPD. Now I'm suspecting a patient of pulmonary arterial hypertension. Now to label it as a group 1 pulmonary arterial hypertension, if I start writing the investigation, eventually the patient probably will have to pay around 50,000 rupees just to be sure whether he will belong to group 1 pulmonary arterial hypertension or not. So in India, how difficult it is for us, particularly whom we are sitting in the OPDs and not in a specialist pulmonary hypertension clinic, to write down all those investigations. So what are the practical investigations we will look for while labeling? I will go to me that what are the investigations which should be done ideally, and what are the investigations which you should do at least for labeling group 1 pulmonary hypertension in our country.
So just to complete what Richard was saying about inhaled nitric oxide, although that part is available in our country, IV prostacyclin and iloprost are not available in our country, so obviously we can't use them. There is a recent study from down south, the Amrita Institute, where they have used IV sildenafil, and that is very well available. And it was a beautifully done study where they compared the parameters which they could identify with inhaled nitric oxide, that is the vasoreactive testing, and they compared it in the same patient after a washout period in the same catheterization with IV sildenafil. And there was a strong correlation in the pulmonary vascular resistance and the mean pulmonary artery pressure which they could identify. Now, this is just an initial pilot study, and obviously it is just one study. But because inhaled nitric oxide, people are not very conversant with its use, and obviously standardization is going to be an issue. That's why this kind of drug, which is available in our country and which we are comfortable using, might end up being used in the future as more and more studies come by. So that is one thing, because that will be accessible to us. About the second part of your question as to because the list of investigations is endless. I'm actually happy you brought that out, because most of my patients who have idiopathic pulmonary arterial hypertension get exhausted by the time we finish with the investigations, not only the duration taken, but financially also. Because to stamp IPAH, you have to rule out all secondary causes, and then you have to rule out associated causes as well. And that is the time where you stamp as a patient as an IPAH, and the list of investigations is extensive, exhaustive. So there was a recent editorial, and I was very impressed by this. Say, for example, if you have a patient who on the X-ray has a clear-cut lesion which you suspect as having malignancy. Now, routinely, first you would get a CT done. Then you would possibly look at maybe markers of malignancy in a patient who has extrapulmonary malignancy. Then you might end up doing a PET CT to decide which is the best place to biopsy, and then you end up biopsying. But the biopsy is mandatory to starting treatment. So if we don't have a typing of the malignancy, we can't start treatment. Now the same principle can be applied to pulmonary hypertension. So instead of first running 25 tests in your patient, suppose if you screen the patient and he has a systolic pulmonary artery pressure greater than 45 on the echo, now and you have a reason to believe that yes, this is a genuinely done echo by a person who's qualified to do it and my reading is reliable, rather than putting this patient through a bundle of tests, the first test to ask for is a right heart cath. Why that becomes relevant is that upfront you know whether the patient has pre-capillary pulmonary hypertension, post-capillary pulmonary hypertension, or a combined pre- and post-capillary, as Apar mentioned. Now, once you know that, you can cut down on the list of investigations. Suppose this patient has pre-capillary, then I don't need to look at the heart side of it or the back pressure side of it. Suppose it is a post-capillary, then I know it is coming from the heart. I don't need to investigate the other aspects. So this thought process, if it can be implemented, will cut down the number of investigations which we are doing. But this algorithm might not be implementable in our country because right heart cath is not commonly asked for. And hence, the list will still continue to be exhaustive. And just to simply put it, you need to first rule out group 2, group 3, and group 4 before you come back to group 1. So you need extensive investigations for the heart, which might include echo, it might include an angiography, it might include a cardiac MRI. Then you go on to group 3, which means you need a PFE, you might need a DLCO, you might need a CPET, you might need a CT. Then you go to group 4, that means you need a VQ scan, and maybe other things which can cause occlusion, which might need further investigations. And then if all of that is negative, you come to group 1. And amongst them, then you look at associated conditions, which means portal pulmonary hypertension, connective tissue disease, congenital heart disease, schistosomiasis, and HIV. Now, all that once you've ruled out, that is the time you stamp by diagnosis of exclusion as an idiopathic pulmonary hypertension. The cost I have calculated, because sometimes I quote this, comes to coolly around 30 to 40,000 in investigating and reaching a diagnosis, which is sometimes beyond the realms of most of our patients.
Indeed, sir. Only one thing to add, sir. Can we use the role of the CT pulmonary angiography, as you rightly pointed out, if you don't have the feasibility of right heart catheterization? So just by doing echocardiography and CT pulmonary angiography, where you can also have the HRCT cards, so you need not to repeat both the tests. Like you once ordered for the CT scan to have an appreciation that you will have certain parenchymal abnormalities, then again you are opting for the CT pulmonary angiography. So any take on that, sir?
So whenever, in fact, this is not only for pulmonary hypertension, in fact, any chronic lung disease, when you ask for a CT, one, you should at least ask your radiologist to look for all these associated things. What do I mean by associated things? That if you have pulmonary hypertension on the echo, you do a contrast study, including an angio, that will tell you about associated thromboembolism. You ask basically for contrast studies which might pick up small nodules and lymph nodes, which might give you a suspicion about whether this could be sarcoid or this could be some other etiology which could lead to this. You can have an esophageal dilatation which will make you suspect scleroderma. You can have a coronary calcium score on the CT chest which will make you suspect left heart disease. You should always look for bilateral pleural effusions because that will make you suspect heart failure. So in all these associated things have to be asked and looked for by your radiologists, because this will not only give you a clue to the presence of pulmonary hypertension, because the moment your radiologist says that the PA to the aorta diameter is greater than 1, the RV to the LV diameter is greater than 1, you already have confirmed what your colleague has said on the echo. And then looking at other aspects, you can reach a etiology of that pulmonary hypertension in that single CT study.
Understood, sir. So now I will go to Dr. Bridges as well as Dr. Richard. Now, suppose you have a diagnosis of pulmonary arterial hypertension. Now, what is the requirement of making any group? Because apart from chronic thromboembolic pulmonary arterial hypertension and little bit of the group 2 where you have specific treatment for the cardiological diseases, if you are going to use the PAH specific therapy, I am more focusing on the PAH specific therapy, more or less they are universal in all the groups. So whether there is, does we really require to make a diagnosis of group 1 or group 5 or group 3? Because anyway you are going to add the same sort of drugs, number one. And I will also take opinion of Dr. Richa on this, and then I will go to Dr. Richa that now we have a patient of pulmonary arterial hypertension. There is a guideline on prognostication where you have a 3-strata score, 4-strata score. There is a reveal score. So how do you prognosticate your patient on your OPD practice? So first to Dr. Bridges.
See, Dr. Devraj, if you have asked this question 10 minutes before, I would be in a better position to answer, but Dr. Dumra and Dr. Apar has already clearly mentioned this thing. But it is very important and very prudent to classify the things. In all these things, in all these groups, group 3, group 2 are more prevalent than group 1, we all agree, I think. So if you want to put this PH under one umbrella term and start using left and right, ERS and PDE, you will not achieve anything. And in fact, use of ERA and PDE 5 inhibitors are more deleterious in group 3 and group 4. We all know these things about. So you need to be very prudent when you use, when you diagnose PH, you need to classify the things because PH is a merged path, okay, of many paths. So you need to stratify the etiology, you need to stratify the things according to the common pathophysiological mechanism leading to PH. And then you need to stratify the things according to the common hemodynamic parameters and the therapeutic targets that we need to offer in all this group. So I agree you have ERAs, PD5 inhibitors in class 1 PH, but that is less prevalent and has a very low incidence compared to group 2, group 3 and group 4. So you need to segregate, you need to move out this group 2, 3, 4. Then focus on group 1 in order to use these drugs. Okay, so it is very important, very prudent to classify the things. Rather than treating it as an umbrella cover, umbrella thing, I think you need to classify the things.
Dr. Richa, please.
So, sir, I agree with Rajesh sir that we need to classify because we need to classify one on basis of the pathophysiology, the common pathophysiology. Then we are also looking at different therapeutic targets, different treatment, as sir rightly said, that in group 3, maybe there is less role and less evident role of using both the therapies, that is endothelial receptor antagonist or maybe phosphodiesterase 5 inhibitors. And also not just treatment, but prognosis. Even in group 1, if we see the subclassification, the prognosis differ. The idiopathic pulmonary arterial hypertension has a much better prognosis than if we talk about familial or maybe the portopulmonary hypertension group, or maybe also as compared to the systemic sclerosis ILD. So we need to look at the prognosis also, and that's why it is very necessary to classify these patients according to the group.
What are the tests which you will do to prognosticate your patients?
So prognosis, as we can see in the latest ESC ERS guidelines, what we see, they have classified into 3 strata groups, that is the low, intermediate and high risk group. And that correlates with the largest registry that comes from US, the REVEAL registry. And they also give a similar score, that is a REVEAL risk score. And basically, there are multiple components involved in some 10, 12 components, but what they are looking at the signs, they are looking at symptoms, they are looking at the WHO functional classification. Very important that they are looking at 6-minute walk test for prognosis. Biomarkers like NT-proBNP, BNP, they're looking at echocardiographic parameters, the right atrial size, presence of pericardial effusion. Then they are looking at the hemodynamic parameters, the right atrial pressures, the cardiac output. So to differentiate the patients into low risk and or maybe intermediate risk and the high risk. Now that's the recommendation by the ESC guidelines, and that's similar by the reveal risk score. In the reveal risk score, there are more components like blood pressure, pulse rate, and there is kidney function, and they also take into age and DLCO.
Understood, but while you are following up, will you give more importance to the physiological parameters, or whether you will give more importance to the measurement directly related with the pulmonary arterial hypertension? Or the physiological parameters like the WHO functional class or 6-minute walking distance, whom do you give more importance?
Definitely the WHO function classification comes first. It's easier that we are looking at the clinical symptoms. Then I would also like to look 6-minute walk test is easily done. So 6-minute walk test is definitely, I'm looking at the follow-up also and at the baseline risk assessment also. Then echocardiographic parameters also. And yes, I will do NT-proBNP on the follow-up also. And if required, then maybe going ahead with the RHC or the specific hemodynamic parameters assessment in these patients. So another topic that you talked about was the 4 risks. That is also one of the, it's more refined risk assessment that is done, and with the intermediate group is divided into 2 forms, the intermediate low and intermediate high. Just a more refined form, because majority of the patients, they lie in the intermediate risk group. And so for a better prognostication, they have been divided into 4.
Like the pulmonary embolism guideline one. It's like the pulmonary embolism guideline.
Yes. Intermediate, low risk and high risk.
So now I will like to take an opinion of Dr. Mihir that how do we assess the risk? This is more or less like the same prognostication. So do you want to add anything to that, Dr. Mihir? Or what does the guideline recommend anything apart from what Dr. Richa has already told?
So not much, sir. So other than that, the comprehensive risk assessment is something that is recommended right at the start. And later on a follow-up basis, we ask for a fewer number of tests for these patients and a fewer assessment values, parameters that we are looking for. Primarily at the start, we want to make a risk assessment because as per the present guideline, based on the risk assessment, your therapeutics are likely to change. And your higher risk patients are those who are likely to get combination therapies with prostacyclin analogs perhaps, in contrast with your patients who are lower risk. So from the registry, we know that if the patient fits into a lower risk category, he has a low risk that is less than 5. In contrast, risk category, it is a more than 20% risk at least, and your intermediate patients are in between. This includes, as Dr. Richa has already told us, your assessment, which is the functional class of the patient, how fast the patient has progressed, whether the patient has a syncopal episode frequently, then he goes into a high risk category, and so on and so forth, including your echocardiographic measurements, your if you have a cardiac MRI, whether you have right ventricular ejection fraction failure.
Since we are running out of time, so now I will go directly again to Dr. Richa. So since you are working in a PH clinic, so I don't want to know about what are the drugs which can be used. What are the drugs which you are using right now at your PH clinic? Suppose you have a patient of group 1 pulmonary arterial hypertension. So what are the drugs what you are using right now?
So phosphodiesterase 5 inhibitor is the most commonly used, and tadalafil more and rather than now sildenafil that I see. And then bosentan is, I can say, the least commonly used in the clinic.
Everyone will agree probably.
Yes, bosentan is the least, maybe because of the drug interaction, maybe because of that. And ambrisentan and also Riosigott also has been used, and maybe as I've seen patients like in the clinic, they have been switched from maybe phosphodiesterase 5 inhibitor to Riosigott for maybe as an escalation of therapy of patients who are not responding. And now that we have, since last year, Selexipag also, some very few patients have seen on the Selexipag drug also. But the cost of Selexipag is very, very high. So yes.
Very high. Yes. Dr. Dumra, what will be the initial treatment of choice? Now, suppose you have a patient of pulmonary arterial hypertension. Suppose I will take it as a case of intermediate high or the high category. So what are the agents we will start with?
So primarily most of your patients who come to you are usually in functional class 3. You would rarely come across a functional class 2. So by and large, the guidelines are pretty cut and dried, and we have both agents available in our country freely. The choice will be based on the ambition trial. You can start with tadalafil with ambrisentan, You also have a new trial where you can combine tadalafil with macitentan. Both these drugs, both these combinations are very well approved. There was a brief study with triple therapy in the high risk group. When you ask, suppose the patient presents to you in high risk group.
In India, sir, how will compose your triple therapy group in India? And what will be the components of that triple therapy in India?
So, as far as the data shows, the double drug did not, the triple drug, macitentan, tadalafil with selexipag, the Triton trial, did not show any significant benefit over the dual drugs, although there was a trend towards decrease in progression. So that was one endpoint which we can explore in the future. So if the patient does present to you in the high risk group, and obviously you believe you want to give him the best upfront, then you can go with the triple drug, all three oral, because we don't have access to any parenteral prostanoids in our country. So selexipag, macitentan, and tadalafil. That will be the triple drug. Having said that, you can very well start with the double drug, and if the patient does not show decrease in the risk category, then you can add the triple drug as a sequential, the third drug as a sequential combination. That will be selexipag. There is also one other option where you can start with the macitentan and you can, instead of tadalafil, use Sigma. That can be substituted for tadalafil. So these are the three triple drugs which you can use.
Agreed, more or less, sir. Dr. Oppar, among the ambrisentan, bosentan versus macitentan, now obviously we all know that bosentan has a lot of hepatic dysfunction as well as a lot of drug-to-drug interaction. So, any data between ambrisentan versus macitentan?
So I don't know if any.
And at what dose you will start the ambrisentan dose?
See,
will you uptitrate gradually, or you will start straight away with the highest possible dose of ambrisentan?
So for me, normally I would like to start with the highest dose, and if the patient is not tolerating, then probably step it down rather than up titrating the dose. I'm not aware if there is any head-to-head trial where bosentan versus ambrisentan have been compared in terms of efficacy and tolerability. My maximum experience has been with macitentan. So this is a drug which I most commonly use. Probably because of the bias of the patients that I have, most of my patients are also at a point of hemodynamic compromise with right ventricular dysfunctions in place. So a serious side effect that I see in all of them is systemic hypotension and appearance of headaches with all the drug therapies put together. So macitentan is slightly better is what I have seen in my patients from this side effect profile. So again, starting from a 10 milligram dose rather than starting from a 5 milligram dose. And then if the patient is not tolerating, going down to a 5 milligram dose is usually what I practice over here.
Dr. Richa,
Yes,
any comment on that, and when to switch? This is another part. Suppose you are continuing on a particular treatment basis. Now you have assessed the prognosis. The patient came to your follow-up. Now you decided to switch to another class of drugs. Now because we in our hands have a very limited option. So how do you then deal with? You straight away refer the patient to Dr. Oppar, or do you want to give certain sort of medications again?
so just to add to the first part also, sir, the drugs that you asked me that what are being used, so they are using inhaled iloprost also. And if
Is
I'm
it
not wrong,
available in India?
yes, this is the cost is very high. And also they are using subcute trepoprostenol, if I am not wrong. It is just that the cost is high and they put the tunnel catheter. And that
How
is
much
being
expensive it is, the iloprost? Because now it is also recommended in the guideline of ILPF. You all know it is probably the only agent.
the exact amount lakhs.
Per day therapy for inhaled iloprost comes to around 2,800.
Yeah, so annually it's something that comes in lakhs or something. So that's what I remember.
It is available, sir.
It is available. Ventilator is available in India. So, when we are talking about that, so that was the other point I wanted to make when we were talking about vasoreactivity testing. See, we talk a lot about inhaled nitric oxide, but there is a practical issue. Inhaled nitric oxide is only available as a closed system. So you need to intubate the patient in order to give inhaled nitric oxide to do a vasoreactivity testing.
Many centers are nowadays also using high flow oxygen probably.
The best results and the only standardized therapies as of now are inhaled nitric oxide or inhaled iloprost or IV iloprost for that matter. Adenosine, high flow oxygen, all this is, it is not used, it is not standardized. So when we're talking about standardized vasoreactivity, it is inhaled nitric oxide. But I think availability of this inhaled iloprost has changed parameters in the last 2 years. I mean, for the last, at least for the last 8 or 9 months, it is freely available in our country in the nebulized as well as the nasal spray form, which can easily be used. So vasoreactivity testing has become much more easier with availability of this nebulization form.
Dr. Mihir, since we all are pulmonologists and in our day-to-day OPD practice, we are seeing mainly pulmonary patients. So now my patient of COPD or ILD who is found to have a pulmonary arterial hypertension, in that case, what are the drugs or medication he will start with straight away? Suppose a patient of COPD with a pulmonary arterial hypertension, pulmonary arterial systolic pressure of around 50. Now, will you treat a pulmonary arterial hypertension? Is there any requirement of treating, or you will treat just COPD per se?
So, per se, sir, in a majority of our patients that we are seeing with lung disease, our present understanding would be that there is likely to be a paradoxical worsening of the patient if we give him some vasoactive medications while the patient has a predominant lung disease and not a arterial hypertension, so to speak. In our patients, however, when you go to the severe pulmonary hypertension classes, there is some data that you could possibly consider using the drugs, which they have even tried with sildenafil, etc., but not too much in favor of it. In fact, in the interstitial lung disease group, they have tried treprostinil also inhaled in the increased trial, and it has in fact been approved also for usage. But these again are not our frequent, and we would possibly want to treat the disease more. Oxygen, as we know, is perhaps the best drug for most of our patients who have this kind of involvement, and for the diuresis also. I'm sure something that we will be covering at some point would be something that we would be using. We've had trials like the RISE IIP trial where they had to actually stop trials when they had to give vasoactive drugs like deoxyguard because of the increased mortality. And so, as a thumb rule, generally with our lung disease patients, possibly consider not using it, treat the disease. And only in severe cases, maybe if there's nothing else you want to experiment, you could consider.
No, I'm just putting a practical question. A practical OPD patient, that is a patient of COPD who is on triple therapy. Now he's having a saturation of 96% on room air, and with the pulmonary artery systolic pressure of around suppose 40. Now, will you advocate long-term oxygen therapy in this patient?
No. So long-term oxygen therapy as such with this particular
or will you add anything PH specific drugs in that patient of COPD, or will you continue with the triple therapy?
Continue with triple therapy would
triple
be.
Therapy means the inhaler triple therapy.
Inhaler triple therapy is something that I would possibly consider.
Sir?
And so there are a few things which we need to sort of clarify here. I'll start with this question about group 3 pulmonary hypertension and whether you should treat. So the question which you asked, a patient of a saturation of 96 with elevated pulmonary artery pressure. So this patient need not have group 3 pulmonary hypertension for all I believe. This could be a patient who has group 1 in association with COPD. So there is more circulatory limitation than ventilatory limitation. So oxygen will not help this patient. A vasodilator might help, provided we can prove this is pre-capillary pulmonary hypertension, which is group 1 and not group 3, because pre-capillary hypertension, pulmonary hypertension can be group 1 also, and it could be group 3 also. So there are two phenotypes which we commonly see with group 3. One, which is called the adaptive phenotype, which means the rise in the pulmonary artery pressure is proportionate to the severity of the lung disease. So if you have an FVC of less than 40% in a patient with ILD, and if you have a PA pressure of 45, that is proportionate. But if you have an FVC of 75, and if you have a PA pressure of 65, that is the maladaptive phenotype, where the pulmonary artery pressure goes beyond the severity of the lung disease, and the same thing is mirrored for obstructive lung disease like COPD as well. So out of proportion elevation. Now, in the maladaptive phenotype, among COPD is what we call the COPD vascular phenotype. There is a specific name for this entity, and this might be the only phenotype where you might end up possibly trying a pulmonary vasodilator under supervision. Now, to what Mihir said about the general rule of thumb that when you give vasodilator to a patient with chronic lung disease, the VQ mismatch worsens, and you should avoid doing it in these groups of patients. Now, again, that is not a blanket statement. See, what happens is that when you obviously give these patients vasodilator, the pulmonary preload increases and you might end up increasing VQ mismatch. But if you are using it in the maladaptive phenotype where the pulmonary artery pressure is disproportionately high, you might decrease the oxygenation, but you might improve the cardiac output. It is like the principle of atrial septostomy, which was being practiced for severe pulmonary hypertension. So what you do is you make an opening in the interatrial septum, which will decrease the saturation of oxygen when you measure it, but it will increase the systemic cardiac output. So the cardiac output will compensate for the decreased oxygen, and the patient will feel better, although his oxygen saturation will go down. So in these groups of patients, maybe when you give a vasodilator in a maladaptive phenotype, your saturation might drop from 90 to 87, but your cardiac output goes up. So the patient's ability to walk, 6-minute walk distance, quality of life goes up. And when you have a decrease in saturation of oxygen, you can always go on to increase your long-term oxygen therapy from 1 liter to 1.5 liter or 2 liters. Because these patients are already group 3, so they will always be on oxygen. Now, if there is a disproportionate fall in the saturation, say you are doing 90 with 1 liter, and now you are at 82 or 80 with 1 liter. That is a significant fall in saturation when you have started a vasodilator. This is not your right choice of patient. Withdraw the vasodilator. But if it is a drop of 2 to 3%, but the patient starts feeling better, the 6-minute walk distance goes up, increase your oxygen, continue giving the vasodilator, keep him under supervision.
Just to add Dr. Dumra's clarification, I would like to add one point. We are living in our own world. We are living in assumption that only one group exists in one patient.
Yes.
I have one patient who has EF of just 20%, is fitting into class 2. He's the severe COPD patient fitting into class 3, group 3, and he had pulmonary embolism 3 years back, fitting into class 4. So this patient is having classical 2, 3, 4. So it is very prudent when you are dealing with a COPD patient who is maintaining saturation 96% with a mean pulmonary artery pressure 45. Start thinking something different. That I am dealing with some other pathway of pulmonary hypertension. I am dealing with some other stratification. I am dealing with some other pathophysiological mechanism leading to pulmonary hypertension. Rather than fitting that patient into class group 3, try fitting them into or try listening to them, assessing them again for group 2, group 4, group 1. So one patient, one group doesn't mean that the patient is fit for one group. He cannot be fit. He cannot adjust it in group 3 or group 4. Okay. So you have
very
to
Dumra as well as Dr. Brijesh. Sir, I am cutting you short. So now I am going to the group 4 pulmonary hypertension. For that, I want to take opinion of Dr. Richard. Do you straight away go for CT pulmonary angiography, or again you will go for VQ scan to rule out or more of an exclusion test, or you will straight away go to CT pulmonary angiography?
No, I think I'll go first for VQ scan definitely, because it's a good screening test with a good negative predictive value. So, and highly sensitive. So if definitely there is a normal VQ scan, then definitely I might not go ahead with further until and unless there is very high suspicion of C.
But you will agree that it is very difficult to do. It is very easy to do a perfusion scan, but to do a ventilation scan, particularly in those patients of COPD or ILD, it will be very challenging. Logistically, it will be very challenging to undergo the VQ scan.
And these days, I think most commonly done is the perfusion scan, and then yes, the perfusion scan. And if you find, suppose the patient doesn't have any underlying lung disease, and it comes out to be normal, then we can easily rule it out. So yes, more easily available is the perfusion scan.
So why not PPA? You want to avoid that contrast?
If at all. Like, but if suppose my patient is not having any underlying lung disease, then definitely I'll first go with the perfusion scan, because if it comes normal, then why shall I go ahead with further giving him contrast and going for CTPM?
And now you have a patient, suppose you diagnose this as a case of chronic thromboembolic pulmonary hypertension. So now you will add obviously anticoagulation. So do you add any PH specific therapy in combination with the anticoagulation? I'm not going to the surgical aspect. I will go straight away to Dr. Apar. So will you add anything PH specific drug, or will you add any just anticoagulation per se?
Only if the surgeons label that the patient is inoperable, maybe, or the patient denies that there
Yes, usually inoperable, but in that case you will add also, in addition to anticoagulation, you will add the PH specific therapy.
Yes.
So any PH specific therapy, what you will recommend in those kind of patients?
I think the most comfortable that I will be with Riocigod, because it's most
and it is also written in the guideline.
Yes. And
So
also
now I will go straight away to Apar sir. So now you have all those patients who have been screened for all those groups, who have been treated with all those drugs. Now, whom should we refer for lung transplant? How to decide whether he is a patient of heart lung or lung transplant? So how will he go, and what is your experience, whether we are getting more and more experienced in referring the right category of patients to you, or still it is the old what we are seeing? So what are the patients who should be referred for lung transplant in a patient of isolated pulmonary arterial hypertension, as well as patient with coexisting comorbidities with pulmonary arterial hypertension?
So, Devaj, let's bring about some conceptual framework into this question. So, I'm not going to cite the guidelines which have been put forward by ISHLT. Maybe we can do that later. But let's just understand where and when should we think about transplant in these patients. Now, when we're looking at group 2, or when we're looking at group 3, or maybe even 4, pulmonary hypertension over here, pulmonary hypertension is not the basic pathology. It is, if we can say, a complication of the underlying disease process, which is further causing worsening of symptoms and further causing worsening of the disease in these patients. So appearance of any pulmonary hypertension in these patients should be indication enough to refer them to a transplant center. That doesn't mean that we are going to transplant them right away, but a dialogue needs to be created right at that point of time. So all your ILDs, all your COPDs, these are the right candidates that whenever they have pulmonary hypertension, you should start talking to them about thinking of a transplant, and also connect them to a transplant center so that they can get prepared that over a period of time, once therapy fails, they will all become candidates for lung transplantation. Now, when do they actually need to be transplanted? Again, then we go back to the guidelines that if they have any complications like hemoptysis or any worsening of symptoms, even despite therapy, they come to a category, high risk category, and by the HA functional class 3 or 4, then yes, they will be taken up for transplant. Now, when we talk about group 1 PH, when we talk about pulmonary arterial hypertension, here the guidelines are a little bit rigid that once you hit category 2 or category 3, you should talk to them about transplant, because these are the patients who will worsen despite whatever therapy you give them. And these are the patients that we call as a ticking time bomb. If you ideally look at the transplant cohort, all your group 3, COPDs or ILDs, these are the patients who will exacerbate not because of the pulmonary hypertension. They will edge near to fatality because of the worsening of their underlying disease. But the group 1 PH, these are the patients who come into your OPD walking and can fall down at any point of time and collapse. You don't want that to happen. So these are the patients who should be referred at the earliest possible failure identification of medications. So if despite maximal therapy, whatever is available to us, they are still proceeding to have increase in their symptoms and a fall in their quality of life, they should be referred for lung transplantation at that very point of time.
Well explained, sir. So just one single subgroup, systemic sclerosis, pulmonary arterial hypertension. Dr. Mihir, any particular drugs, or will you focus on the immunosuppressives as a whole?
So, am I audible, sir?
Yes, you are audible.
Yes, sir. So essentially for systemic sclerosis, interstitial lung disease, sir, with a patient who has possibly mild to moderate pulmonary hypertension, we can consider, making your immunosuppression as your stronghold. And as the severity of the patient's pulmonary hypertension increases, your decision regarding your therapy, obviously with vasoactive drugs, also increases. In your low intermediate risk patients, you can consider monotherapy in select cases, but otherwise, as per our AMBITION trial, we go for combination therapy for most of our patients. Additionally, if they are in the high risk category, now you can consider addition of prostacyclin analogs also, or our PRAs, which are available as in selective for our patients with systemic sclerosis. In systemic sclerosis ILD, of course, it is important also to find out whether the patient has, as we were discussing with the COPD patients, whether there is another aspect to the patient's pulmonary hypertension, so to speak, whether there's a left heart disease involved also, because then your vasoactive drugs might also make it a little difficult to manage this particular patient. So if you have a group 1, group 2 with the systemic sclerosis also, then maybe you need to be a little more careful with your vasoactive.
Just last question. After that, I will go to Dr. Domra, sir. So, Dr. Brijesh, there are two parts. We already discussed about the PAH specific therapies as well as treatment specific to that disease. Now, how should we treat the right heart failure in a pulmonary arterial hypertension patient? Do you add any specific drugs, diuretics, or anything to look after the right heart failure? You are not audible, Brijesh, sir.
I'm sorry. I think we all know if the patient is coming up with right heart failure, with volume overload, with palpable liver, raised GVP, we all need to decongest the patient with the help of diuretics. One thing I would like to add here, diuretics will not gonna improve the mortality in these patients. It will only help you to tide over the crisis in these patients. So all these digoxin, diuretics that we add, it will only help in tide over the crisis. One thing I would like to add here also, there was one question that the prognostic markers in PH patients, whether it is pro-BNP or drop-Is or not. So I just share one case scenario. 3 days back, we had one patient who was a known case of CTEF. She came with shortness of breath in our emergency because she was labeled as a case of CTEF. So the message conveyed to me that she came with right heart failure because she's a known case of CTEF, and we want to start straight away. We want to put her on diuretics and oxygenation. Her drop-I was 44,000 at a time. So what I would like to add here, sometimes we miss these kind of patients because we are so rigid. We don't want to change our diagnosis. We don't think that my patient of PH, my patient of CTEF can also have myocardial injury at any point of time. And these are the patients who have very high risk, high incidence of ACS and myocardial injury. So this is one thing where we suspect right heart failure because of the PH, because of the CTEF, and these patients are actually the case of ACS or MI, then ended up in right heart failure. So drop-I is a marker of mortality in PH. We usually follow the patient with BNP, but if the patient is coming up in crisis, we should also get this drop-in I done. Coming on the question, diuretic, yes, should be given if the patient is in right heart failure. Yes, it should be given. One thing important here, all our ERAs, endothelin receptor antagonists and PDE5 inhibitors, they also cause pituitary edema in our patient. So do not use diuretics unnecessarily in this patient, just by seeing the pituitary edema in these patients.
Particularly MD center, you will agree.
See, one more thing, Devraj, when we are talking about right heart failure, I think we have to highlight the importance of agents like dobutamine and milrinone. Milrinone has been very extensively used now, and this is a brilliant agent to improve the right ventricular output, to improve the right ventricular contractility. And the good thing is now Baxter has come up with pumps which can be easily connected to a peripheral vein and it's a slow release pump which can be given to the patient for use at home. The milrinone that you will dilute and instill into the pump will last for a period of about 3 days to 5 days, depending upon the quantity that you want released. So this is something that can be used for your advancing PH for patients who repeatedly come back with right ventricular strain or right ventricular failure features. So apart from your diuretic,
Probutamine, do you think it will be more or less erythemogenic? It will be safe to use?
Probutamine, I agree, only in the clinical setting, but milrinone, that is why I said, can be something that can be really helpful for our patients.
So we are now coming absolutely to the close of our wonderful discussion. Now I will go to each of the panelists. Should we make an Indian guideline on pulmonary arterial hypertension? And then I will request Dr. Dumra to summarize.
Plain and simple, yes.
What should be the crux of that guideline to make the things more easy? But since we are all advocating right heart catheterization, so we should follow the ESC guidelines.
Yes, I think we should have our own registry of this PH. Before we have guidelines, we should have our own data. Before we should embark on the guideline, and it will definitely help in individualizing the treatment, because we are just relying on the Western data. We don't have our data. We're just relying on the Western data, Western incidence. So I think we should have our own data, because our population is totally different from the Western world.
Dr. Mihir?
Yes, sir, indeed. We need Indian guidelines primarily because we don't have all of the availability of all the drugs in any case. So there has to be a practical aspect to it. Maybe also highlight which centers are doing RHCA so that we can have a better link up, and then, make our own management protocols which can be done at a center which is lesser than only the advanced centers.
I think Dr. Abbar, you should take the lead in that.
Yes.
Yeah, I mean, see, I have been advocating this for the last couple of years also, that we as pulmonologists should not shy away from right heart caths. So this is our baby, this is our domain. I think depending upon the cardiologist who really does not want to interfere with the right heart is not going to help our patients in any ways. And then it's not only about the right heart cath, as Mihir mentioned and we've already been discussing, we do not have all the drugs which the guidelines mentioned available to us. Plus, even when they are available, like the inhaled iloprost or even Selexipag for that matter, how many of our patients, I think more than 70% of our patient population will not be able to afford all those drugs. So I think keeping all those challenges of diagnosis, challenges of therapy, and then lung transplantation, maybe not even 1% of the population can be offered this therapy at this point of time. So keeping all these challenges in mind, I think a practical approach, maybe not a guideline if such, but at least a practical approach to managing these patients is something that is needed right away. And maybe Harjit can add a little bit more to that.
Dr. Richa?
Yes, I totally agree that because of the resource limitation, the cost is a huge factor, availability of the drugs. Definitely, we should have Indian guidelines. And a more of a practical approach, like Apasa said, it's more of a practical approach rather than just a theoretical, just guidelines per se.
Now I will go to Dumra, sir.
So I think most of the points have been covered by all the panelists, as Apar rightly put it. I think the guidelines are needed not because the present guidelines are not crystal clear about what we should do, but we are a resource limited setting in certain contexts, and we are basically a little hesitant in trying out what is already available in the real world. So some of us will not have accessibility, but some of us will try to take the easy way out by looking at an echo and not looking at a right heart cath. So in that kind of a situation, if there was some guideline, I would not put it as a guideline because guideline will need proof of evidence, which we won't be able to generate, but some kind of an expert consensus for low middle income countries, that would make a difference. So some important pertinent points regarding India, like all of us have said, right heart catheterization and vasoreactive texting is difficult or not practiced in our country. Group 4 CTEPH is usually underdiagnosed, and pulmonary end arterectomy is seldom asked for, even in spite of the fact that it is available, and usually we take the easy way out of giving drugs. In fact, Group 4 CTEPH is one subset of pulmonary hypertension which is reversible and treatable, beautifully treatable. Thirdly, calcium channel blockers are overprescribed in our country, where they are usually not effective in the pulmonary hypertension, but the physician crowd and a lot of senior people tend to overprescribe there. And we need to cut down on that practice. Lastly, basically cost constraints and lung transplants are still a luxury. So, frankly speaking, with those limitations in mind, we need to find a middle path where we have the balance of proof and practical suggestions, which could lead to an effective management protocol for our patients in the Indian context.
So, agreed, absolutely, sir. So, just going to the questions. So, most of the questions what we received have been answered already by the panelists. One of the physicians asked regarding the ILD patient whether the pulmonary arterial hypertension should be treated from the very beginning. So, more or less, everything has been discussed and highlighted. So, now I want to thank all the panelists as well as the lead expert, Dr. Dunda, for your excellent elaboration of the topic. The message what we got from our discussion, that we should not be afraid from sending the patient for right heart catheterization. If I want to take only one message from our discussion, that it is an integral part for diagnosis of pulmonary arterial hypertension, and we should at least make our patients more aware for lung transplant. Even though they may not land up for lung transplant, at least from the very beginning, when we are initiating the treatment or when we are suspecting that the patient may eventually require, we should make them aware. So thanks to all the panelists as well as lead expert Dr. Dunda. Thank you.
Thank you.
Thank you.